And so welcome everyone. My name is Dr. Maureen Nash. I'm a geriatric psychiatrist and as well as an internal medicine physician. I'm going to be talking about advanced dementia. This is just a little bit about who I am. I have no financial conflicts of interest. Off-label use of medications will be discussed as there are very few medicines that are on label. Off-label means treating someone for a diagnosis or at a dose that the FDA did not give an indication for and is unrelated to whether or not there's evidence to support the use of something. So, is dementia a cognitive disorder or a behavioral disorder? Or is it the loss of functional abilities? If you look at the DSM-5 and its definition of major neurocognitive disorder, which is where dementia falls in that diagnostic categorization, they talk about cognition and functioning as the primary drivers of major neurocognitive disorder. And they have about a page and a half in there about behavior disturbance for people who have dementia. If you look at the World Health Organization's definition of dementia, what you'll find is that it's more a tri-legged stool with cognition, behavior, and functional abilities. The more recent paradigm is really to consider dementia as chronic brain failure. And some people think of delirium as acute brain failure. And you might recognize the analogy here to heart failure. And the reason that this sort of analogy is being made is because just like heart failure is often a terminal diagnosis, though that decline in functioning occurs over about 5 years on average for a person. Dementia is a brain failure that occurs probably over 10 to 20 years, although most people are not diagnosed until late into the illness. But changes have been going on in the background in the brain for decades before the first symptoms. I always want to point out that Alzheimer's has always been seen as a behavioral illness since the very first case described in the medical literature, which was Dr. Alzheimer's case. And the reason he met Auguste D was because of her behavior disturbance and her psychotic symptoms, which are quite common. I want to also point out that the use of psychotropic medications precedes the dementia diagnosis nearly uniformly. And I realize this is kind of a small slide, so you could go to the BMJ open access article if you wanted to look at this in bigger print. But essentially, what you'll notice is that people are starting to treat psychosis, depression, anxieties, and sleep disorders before or at the time of diagnosis. And so those are all behavioral symptoms of dementia. And they are often present, many times are even the presenting symptoms that lead someone to a provider's office. And of course, one of the things we all want to pay attention to is aggression. And I think with good treatment, we can really help decrease this from occurring and certainly decrease it from seriousness. The good news is that most of these aggressive episodes do not, the vast majority, do not lead to any injuries, but one injury is one too many. So what I would like to advocate is considering all behavior as communication. And that's most true for anybody who has limited abilities to verbalize, and that would be nearly everyone with dementia. And so when somebody has what we think of as behavior disturbance, one of the key things to think about is which category of need is this person trying to communicate to us? Are they having physical discomfort or distress, constipation or pain? Are they having emotional symptoms of anxiety or depression? Is the environment too taxing for their abilities? Or are they facing loneliness and other social challenges related to their dementia? There are a lot of different ways to measure neuropsychiatric or behavioral symptoms related to dementia. The NPI, or Neuropsychiatric Inventory, has these categories in it and is a nice instrument to use because it is applicable to all types of dementia. Most instruments are actually designed to work with people who have Alzheimer's disease, which is certainly the most common kind of dementia. But most instruments that look at behavioral disturbance do not actually apply to all types of dementia. And that's one of the things that makes the NPI separate and stand out. And if you look at this, what you'll find is on any given day, a significant percentage of people with dementia are having behaviors. There are many studies with different graphs. This just happens to be 2 nursing homes in Europe, but there are similar studies in the US. And what you see is the bottom list of behavior disturbances are the most common in people who are living in a facility: irritability, delusions, apathy, disinhibition, agitation, aggression, anxiety, aberrant motor, and depression. So more than 1 in 5 people with dementia are having those symptoms any day. One thing that's not on the NPI is inappropriate sexual behavior. That's not all that common, but it really concerns people when it does occur. We used to think of that as really a sexual kind of thing, and we had a big focus on the actions. A more modern view of sexually inappropriate behavior is really to look at, is somebody intimacy seeking, or are they disinhibited? And you have different treatment plans and care planning for people depending on what appears to be motivating the person. I will also put out there as a caveat, many people call things sexually inappropriate that are not. For instance, I've had people describe someone urinating in a plant pot as sexually inappropriate behavior because the man who was doing it unzipped his pants so that he could pee. What I would call that is goal-directed activity. So I think that one of the big key things is really to get details rather than look at what people will tell you there's inappropriate sexual behavior, and the next question should always be when somebody describes something is, tell me exactly what you saw and heard, or what somebody who was there saw and heard, and describe for me as if I was watching a scene on a TV show so that I can really understand what's going on. And that's the way to really get more of the details. Interestingly, aggression in people who have dementia is really tied to 2 things. One is when you tell somebody no, or you take something away from them. And the second big time of aggression is with personal cares. And what they found in this particular study, which is also quite common in other studies, is that the majority of incidents that were described as violent were occurred through only a very small minority of the residents, and injuries were very, very rare. And the most frequent way to diffuse a situation is talking with a person, though not necessarily talking to them about what they said or did. It's more distracting, trying to figure out what need they have that's not getting met and meeting their need. One of the other big things to think about is really, these are some common symptoms we see in people with advanced dementia. And I think that these symptoms are often misinterpreted. And so when I see these symptoms, I'll tell you what the first thing that occurs to me is pain. And I'm not sure that that's the first thing that occurs to everybody else, but the pain AD for advanced dementia is what the AD stands for, is a valid and reliable scale for managing pain in Alzheimer's disease. In advanced dementia, including Alzheimer's and other types of dementia. And what you'll see here these are really common things that we see. We see people who pace. We see people who are inconsolable, who have repeated calling out. The most common explanation for all of those symptoms in someone with advanced dementia is pain. We're doing a better job at recognizing pain, but we're not doing a better job at treating pain in people with advanced dementia. And that is one of the things that does concern me a little bit with all of the emphasis on avoiding inappropriate opiate use, which I certainly agree with as a clinician, but I also want to make sure we're not avoiding appropriate use of pain medications for people who have advanced dementia. Just a reminder to all the providers who might be listening, any discussion of treatment really involves informed consent. And when you have an informed consent discussion with a decision maker who may be the patient or their surrogate, depending on the situation, you want to discuss the risks of the treatment, the benefits of the treatment, and any alternatives to consider. And it's also important to include the risk of no treatment. Common risks of no treatment are people becoming injured or becoming fearful of being injured, people losing housing and getting stuck in a hospital, social isolation. One of the saddest stories I ever heard was somebody who had been discharged from the Tuolity Center for Geriatric Psychiatry. And when he returned to his facility, the staff at the facility told everyone, staff and family members and peers, to avoid him because the staff were afraid of him. He was a former sheriff. He was a large, strong fellow. He actually hadn't done anything aggressive since his medications were stabilized and his treatment plan was beefed up with non-pharmacological interventions. But because he had a distant history of an aggressive episode, everybody was very afraid of him. And so they really totally shunned him. And I think that's pretty sad when you're living at a memory care unit, that you spend the rest of your life with everybody avoiding you and afraid of you. I want to just give a note about evidence. There are a lot of challenges with the evidence in the literature about treating people with dementia and behavior disturbance, and these are some of the challenges. Almost all of the studies look at people with mild disease, when actually medications for behaviors related to dementia are most effective the more severe the behavior is. And so although there are studies of people who have severe advanced dementia and significant behaviors, they tend to be smaller and less well controlled because, really, if you think somebody is a danger, there is no control group. You can't just let somebody continue to be dangerous. So you're not going to get an RCT, a randomized controlled trial. Also, inclusion criteria are very challenging around studies of dementia, that people don't tend to divide up the people with dementia by the type of dementia, which is really important for determining treatment. You can't really determine the appropriate treatment unless you know what type of dementia a person has. And a lot of people really just look at dementia as if it was one thing, when in fact Alzheimer's disease, Lewy body, other types of dementia are really common, as seen here. And then finally, the biggest problem with the literature is that most studies allow lorazepam for breakthrough symptoms. Lorazepam is a benzodiazepine. It sits on the same receptors in the brain as alcohol, and it leads to disinhibition, as if somebody had had several drinks. And so anytime a study includes lorazepam for breakthrough symptoms, from my chair, I can't trust what they're concluding from that study, because they have really, you can't judge whether an intervention is helpful or not if people are intermittently getting, you know, a benzodiazepine or alcohol. So the kind of approach that we recommend is that you identify and assess a cause of behavior. And so that involves looking at what the needs might be, the environment, look for psychiatric symptoms. And this is where you want to, in your assessment stage, is where you want to do functional testing, which is what occupational therapists specialize in. And I'm a big fan of using a scale. And certainly the neuropsychiatric inventory, which comes in various different forms, is a standardized scale you can do. I think it's really important to use some sort of scale when you're treating so that you can judge whether or not you're successful. Then you select an intervention. After you've done your assessment, you apply it, and then you monitor. And you will notice that this is basically how all of medicine is practiced. We identify a problem like heart failure or shortness of breath. We do an assessment to see what caused it. We pick interventions, we apply them, and then we monitor. So there's nothing special really about dementia with behaviors as far as the overall approach. It's the details of the approach that are specific to dementia. And when you're doing treatment planning, it's really important to correctly label behaviors. And use language carefully so that when you say hallucinations, you actually are talking about somebody who's being misled by their sensory system. When you say delusions, this is somebody who has fixed false beliefs. When you say somebody has psychomotor agitation, it's because they're moving all the time or randomly or oddly. I think it's important to clarify the diagnosis. And in fact, that's actually a quality metric by some of the national organizations to clarify the dementia diagnosis, to discuss it with the person and their family, and to talk about the long-term plans for that, to educate people that dementia is a progressive fatal illness, but there are lots of things we can do to support the person and caregivers along the way. And that's actually something that the older adult behavioral health specialists like Angela Jensen at Central Oregon Health Council can help with. I'm going to review two sets of psychiatric symptoms, those that are amenable to treatment with medications and those that aren't. Generally speaking, the more severe they are, the more treatable they are. Paranoia and delusions, hallucinations are very treatable most of the time. Depression, sometimes if it's a depressive illness, but not if it's a grief reaction to having this fatal illness or this loss of functioning. Anxiety, if it's an anxiety disorder, there are medications for it. But if it's anxiety because your brain isn't working or you can't remember things, that is not treatable with a medicine. And that's one of the things I think where primary care has challenges. They sort of stop at the sadness or tearfulness or at the panic or worry that somebody's experiencing, and then they try and treat people with a medication for a psychiatric illness rather than looking to see if they meet all of the criteria or they have a long-standing history of the diagnosis. Pain is very treatable if you are able to recognize it. Agitation, I think the challenge with agitation is that we aren't all talking about the same thing when we use that word. If you're talking about aggression, then I do think that agitation is treatable with medicines. But I think if you're talking about other things, I think it's not necessarily treatable. And some people mean psychomotor agitation, some people mean aggression, some people mean anxiety. Some people mean social isolation. So there are many different things. Wandering is definitely not treatable with a medication. Another word for wandering is walking. Calling out, unless it's related to pain. If it's related to pain, which is the most common cause, then it is treatable with a pain medicine. If it's not related to pain, calling out is not going to be treatable with a medication, and you have to really treatment plan around it. Repetitive questions, sleep problems sometimes are treatable early on in dementia, but as dementia progresses, it becomes less and less treatable with medications. I just want to highlight a couple things. I'm going to just blow through the next couple slides. There's a lot of concern about atypical antipsychotics and antipsychotic use in general in people who have dementia. And I want to put it in perspective a little bit. There was a pretty large study done by Hubricks and her group, and they looked at nursing home patients in Canada, and they compared the old antipsychotics to the atypical or new antipsychotics, antidepressants, and benzodiazepines. And conventional or older antipsychotics and antidepressants were nearly 50% more likely to be associated with death than atypical antipsychotics. Femur fracture, older antipsychotics were 60% more likely to be associated with it, and antidepressants about 30% more likely to be associated with femur fracture rather than atypical antipsychotics. And benzodiazepines, your risk of death is about 80% higher, or a risk of 1.8. Your risk of heart failure is about 50%. Your risk of pneumonia is 85% higher if you are on a benzodiazepine. Although there may be risks with atypical antipsychotics, I think because of history, I think people sometimes miss the relative risk of that compared to other things, which is really important. When we look at non-pharmacological strategies for dementia with behavior, there's a lot of small, uncontrolled studies that show some small benefit while an intervention is going on. The only thing that shows robust effect for people with dementia and behaviors is caregiver education and caregiver support. And again, almost all the studies of behavioral strategies have been done with mild dementia. This is an older review, but there are more recent reviews, and so far we have not really moved the bar yet, I think because it's so challenging. Mary is just a person who I met. She was verbally hostile. She was scratching, biting with cares. She chased everybody out of her room. She refused food, fluid, meds, care, everything. This is not a picture of Mary. Mary isn't her real name. I met her. She was about 80 years old. She was very frail. It turns out, after a lot of research, it turns out she couldn't understand language. And so what was happening is we would go in to talk with her and we would ask her a question, and she just panicked. She just got very anxious and panicked. And so that's the kind of investigation one needs to do when somebody's having these kind of really just catastrophic failure to survive in an environment. You have to start doing some investigation and see if you can come up with it. And it took us a little bit of time to figure out that that's what was going on for her. She didn't understand language anymore. She couldn't use language, and questions were very anxiety provoking for her. And so she just tried to defend herself and get you out of her room when you asked one. I'm definitely not going to spend a lot of time on this. Hopefully you guys are familiar with the fact that benzodiazepines are the most dangerous psychotropic medication for older adults. There are a couple uses for them, but generally speaking, try and avoid them. When I look at dementia with behaviors, if you're talking about Alzheimer's disease, Parkinson's disease dementia, Lewy body dementia, vascular dementia, or some combination of those 4 types of dementia, which would be 85 to 90% of people with dementia, I think that it's worthwhile considering dementia-specific medications. And so I'm just going to review some of the data. There's a lot more data out there. This was a meta-analysis of data around cholinesterase inhibitors, and what they found was you could stabilize function, behaviors, and global change a little bit, and mostly what you could do was slow decline, including cognition. Sometimes you can delay a nursing home admission, and most nursing home admissions are caused by either increasing behaviors or decreasing functional abilities. So it is an assumption, but it's quite likely that that's why there was almost this nearly 3-year delay in placement in people who were on a cholinesterase inhibitor. There are a few older negative studies for behavior disturbance and cholinesterase inhibitors, but again, this was a challenging study because they eliminated some patients, especially those who were already on the medication of choice or people who were on an antipsychotic drug in the last month. And by doing that, what they did was they eliminated people with moderate to severe behavior disturbance, and those are the people most likely to benefit. So there are other studies. If you look at the UK, they recommend cholinesterase inhibitors for people with mild to moderate Alzheimer's disease. They recommend memantine for people who have moderate or severe Alzheimer's if they cannot tolerate a cholinesterase inhibitor. They recommend trying to avoid antipsychotics in mild to moderate Lewy body dementia, Alzheimer's, and vascular. But if somebody has significant psychosis or agitated, meaning aggressive behavior that's causing distress, they did recommend considering antipsychotics. They certainly recommend cholinesterase inhibitors for people with Lewy body and people who have non-cognitive behaviors. This was one of the earlier studies of memantine, and what they found here was that the use of memantine prevented the onset of agitation and aggression in people with Alzheimer's disease. In the EU, what they found was the combination of cholinesterase inhibitors and memantine was very effective for treating people with behavior related to their Alzheimer's disease. They also found that evidence was weak for cognition as well as ADLs. And again, that's what I would want to highlight, because in the US, when we focus on major neurocognitive disorders, what we really are talking about usually is cognition and functioning. And that's what dementia-specific medicines may help sometimes, but what they help the most are behaviors. And because behaviors have been dropped out of the US definition, though they are in the World Health Organization's definition, I think that's part of the reason why people have missed this part of the story about dementia-specific medications. So what do dementia-specific medications help? I'm just going to fly through a couple graphs from actual studies looking at cholinesterase inhibitors versus placebo, or memantine and cholinesterase inhibitors versus placebo. Here, what you'll find was delusions, apathy, and aberrant motor improved with cholinesterase inhibitors. Here, after 26 weeks, which is a decent time for a study, what we found was agitation, irritability, aberrant motor, apathy, delusions, hallucinations, and nighttime behavior and appetite improved with rivastigmine. And although this is a small study, I have actually replicated this same result in PACE participants in a very small observational study that we did. This is actually in the literature, showing that when you use a cholinesterase inhibitor, you can actually decrease antipsychotic and anxiolytic use in most people, or you can prevent a need to increase the dose, or at least severely decrease the need to increase the dose, if that's not too confusing of a statement. So older antipsychotics have more side effects, but they can, there is some evidence, older evidence in the literature for effectiveness at treating aggression. The American Psychiatric Association developed practice guidelines that are online and that are available for free. The 198-page practice guideline is what I would recommend. There is this very short 3-page article in the American Journal of Psychiatry that doesn't have any details in it. So if you want the details, or you can read my slide, which summarizes for treatment of psychosis and agitation aggression. There's good evidence for risperidone and aripiprazole for psychosis, and there's good evidence for risperidone and olanzapine for aggression. So just some general dosage ranges when we're using those medications. And I want to really touch on a key point that was a very common reason people ended up coming for inpatient psychiatry. They would come because people took them off of the antipsychotic medications that had been working for them. And there was very little in the literature until this Devenant study. And they looked at people who responded to risperidone and said, well, gee, if we stop this medicine that worked to decrease psychosis and aggression, what happens to people? And it turns out what happens to a lot of people, if you just switch to placebo after 16 weeks, 6 out of 10 people relapsed. If after 32 weeks, so 16 plus 16 weeks, you switch to placebo, nearly half people relapsed with psychosis and aggression. And if you continued risperidone for 32 more weeks, so a total of 48 weeks, there was, the longer you were on it, the less chance there was of relapse. And that's actually similar to what we see with treatment of major depressive disorder. So everybody knows about the FDA boxed warnings. I did have a conversation that Senator Merkley's office arranged in 2012. From my chair, there were some problems with the boxed warning. It was all association data, and the causes of death were all over the map, to quote Dr. Loughran. And we don't know why antipsychotics were being used, and they didn't exclude hospice patients. So, what types of evaluations to consider when you have somebody with advanced dementia? You could consider neuropsych testing, but that's really only useful if people have very mild symptoms, because once you have advanced dementia, you're unlikely to be able to sit for 6 to 8 hours of testing. And so what I actually recommend is an occupational therapy consultation. They can assess ADL and independent ADL abilities, and then they can design interventions to go with that. And they really tend to attract a very creative group of providers, OTs. And so they're good folks to ask, how can we work on improving the quality of life for this person? There are behavioral analysis consultations available. Medicaid has a contract for them in every county, and Angela Jensen at the Central Oregon Health Council can help you with setting up one of those. And of course, there are people like Angela, the older adult behavioral health specialists. So, generally speaking, these are the first things that I think of when I'm working with somebody who has dementia and behaviors. I want to get them off of disinhibiting medications like benzos and the Z drugs. I want to get them off of antidepressants unless they had lifelong major depressive disorder. I want to make sure I'm treating pain. I want to make sure I'm preventing constipation and urinary retention. If they do have sympathetic nervous system dysregulation, excessive startle, you can consider some prazosin low dose. We at the Tuolity Center for Geriatric Psychiatry, which is no longer open, but when we worked there, this is really how we treated people with Alzheimer's or vascular dementia. We put them on dementia-specific medications. If they had aggression or psychosis, we used an atypical antipsychotic. If they had impulse control problems, we would consider VPA or valproate. The challenge there is that will accelerate brain atrophy and loss of functioning for older adults with dementia. So you really do need to be careful. And I really would only use valproate if people had failed an atypical antipsychotic, multiple atypical antipsychotics. There are studies out there showing that the association with death for valproate is the same as the association with antipsychotics, without any evidence that valproate is actually helpful for most behavior disturbance. And there is no evidence base suggesting valproate is helpful for aggression, unless it's really an impulsive problem. SSRIs possibly for depressive symptoms, but at a low dose. One of the key things to note about Lewy body dementia and Parkinson's, even before you treat somebody with an antipsychotic, if they have psychosis in Parkinson's disease, that is a predictor of mortality. So they are nearing the end of life, whether you treat their psychosis or not. And it is a big quality of life issue. Just for the record, although pimavanserin, however you say that, is FDA approved for psychosis in Parkinson's disease, there's no evidence that it's any safer or has a different side effect profile from quetiapine or clozapine, and it is much more expensive. So when you're treating somebody with Parkinson's disease, dementia, or Lewy body, again, cholinesterase inhibitor is the first level of treatment. You might want to consider memantine. If a person has depression, you want to look at something that affects norepinephrine and not serotonin. So bupropion and nortriptyline are two commonly used agents that have been studied in Parkinson's disease. Restless legs, you could consider dopaminergic agents, but those worsen psychosis. And restless legs is caused by serotonergic meds. So if somebody is on an SSRI or other serotonergic antidepressant and they have restless legs, the first thing to do is to stop that. And again, quetiapine and clozapine at low doses are the treatments. Frontotemporal lobe dementia is a lot harder to treat. There aren't medications that, there's not a robust evidence base for treating people with FTLD or FTD, frontotemporal dementia. So for paranoia and delusions, antipsychotics, disinhibited behavior, you can consider valproate or even carbamazepine. Sexually inappropriate behavior, consider a one-piece outfit. Lower or discontinue dopaminergic agents, taper off of benzodiazepines. If it looks like mania in any way, like bipolar disorder mania, you want to stop antidepressants. If it's impulsive or disinhibited, you might want to consider a mood stabilizer. Anti-androgen treatment can be helpful for some men, and discharging a patient to a single gender facility or unit can sometimes be appropriate. As you might imagine, there are no RCTs. This is just a list of some of the things that there are case reports about. What I really like to emphasize is the good news is that you and the caregivers do not have dementia, so that you can change, unlike the person with dementia who's really lost their ability to change. That's a part of the illness. So it's not a matter of trying to get them to change, it's a matter of changing the environment and the medications around them. And here's just some unpublished data from 390 consecutive patients that we treated at Tuality using kind of the algorithms that I've outlined. These are their admission scores and their discharge scores. So if we look at terminal illness, which is really, you'll see the bottom graph, that's what the end of life for frail older adults or people with dementia looks like. It's really sort of they call it a prolonged dwindling. The FAST score is used to qualify people for hospice. Unfortunately, it's not a great predictor of mortality in people with dementia. 7C is what you have to qualify for hospice. But if you didn't go through 7A and 7B, then it doesn't help. For people who are in a nursing facility, you can use the minimum data set, and you can actually, there's a formula that Mitchell and her group have designed. And I see I left the reference off of this slide, so apologies there. So these are the kind of things. I myself like the mini suffering state exam. It's one of the tests that has been shown to be the most useful clinically. It's the easiest for caregivers to do. It's short and it's understandable. So you ask, these are 10 yes or no questions. Is the person calm or not calm? Are they screaming, calling out? Are they having pain? And I always use the pain AD for a score of 5 or higher for that. Do they have a decubitus ulcer? Yes or no? Are they malnourished? Are they not eating? Are they needing invasive action? Have they had an ED visit in the last couple of months? Are you ordering blood tests or a catheterization? Are they on any sort of invasive medical procedure that they're unlikely to understand because their dementia is so advanced? Have they had a hospitalization? And then finally, the last two, do you think the person is suffering? Does the family, or if they don't have family, do their caregivers think that they're suffering? And it turns out that instrument, which is 10 yes or no questions, does correlate pretty well to mortality. And I find that this tool is very helpful when I talk to families. And what we find is the higher your level of suffering, the closer you are to the end of life. So that was a very rapid Okay, so now I've got Nirmala Dar has a question. Are all behaviors a form of communication, or can some be due to severe brain dysfunction and impulse control dysfunction? Well, Nirmala, what I would say is yes and yes. I think all behaviors from everyone are a form of communication. And I think if your brain is not functioning well or you're having impulse control problems, I think your behavior is perhaps the only good way of communication. And I think it pays us to listen to people's behavior rather than to people's words, because I think words will distract you from what a person is really communicating. And yes, I did send the PDF of these slides to Angela. She will be able to get them out to you. I apologize that I only finished them late because I was out of town a lot of the last 3 weeks. So I got them to her late, so she wasn't able to get them to you, but she does have a PDF of these slides. I would mention there is a book that I co-edited with an occupational therapist, Sarah Foydell, with some contributions from a psychiatric nurse, mental health nurse practitioner, Sue Rose, that is being published hopefully later in March or the very beginning of April by Springer. And that book is on neurocognitive behavioral disturbances. It's on an interdisciplinary, team-based, person-centered care. So, do you know about the app Dementia Assist? I don't know about that app. So Dementia Assist, free iBook and Dementia Assist app. It's looks like it's based on Teepa Snow's positive approach to caregiving. Teepa Snow is a very experienced occupational therapist who's done trainings actually all over the state. So although I don't know very much about the app, if Teepa Snow is involved, it's probably a pretty reliable. It says here it was created by the Baylor healthcare system, which is a pretty large healthcare system in the South. And it looks like there are Apple and Android versions. And I found that just going online. So thank you, R. Harwood. Yeah, that's a great question, Nirmala. Are there a number of studies about the efficacy of Teepa Snow's approach? I'm not aware of that. Is anybody else aware? So it's the positive approach to dementia care, RCT, randomized controlled trial. So I see a lot of presentations. I see some YouTube videos. I see a description of how it was developed. I don't actually see any studies, just doing a very quick a very quick overview. It looks like the Alzheimer's Association does talk about, they did a review, and what they found was there are many quasi-experimental studies assessing interventions, but there aren't good, high-quality, randomized controlled trials, which I think, unfortunately, the meta-analysis I reviewed was published back in 2005, and again, it is not. There is not a lot of evidence. What there is evidence for, though, is caregiver training and caregiver support. And so, although I'm not sure that Teepa Snow's specific method has been studied, what has been studied is what she does, which is caregiver training and caregiver support. So I think I'm not sure that there's a lot of study about her specific method. That's a great question about how Oregon selected that, and I think perhaps somebody at OHA or DHS could answer that. I do know people are very concerned about the risks of psychotropic medications, and I think that has led a lot of people to rush towards behavioral interventions, whether there's evidence about them or not, which is a little bit of a challenge. Medications are certainly not the answer to every problem, but if somebody has significant psychosis or aggression, I don't think you're going to be able to do behavioral interventions with them successfully. If people have mild symptoms, then I think it really is a matter of putting your investigator hat on to investigate what might be causing behaviors.